Okay, I'll be recording on chapter 20, heart and neck vessels. I will be providing some pictures in here, and you will see on some slides that they are bolded. So I'll go over that as I go through each slide, okay? Okay, so right here on this slide, we have a picture of the precordium, which is the area on the anterior chest, the front of the chest, overlying the heart and great vessels. Okay, you see it marked there. And a lot of this is anatomy that you should have taken already, so I'm not going to go intensely over all the parts of the heart. But the base and the apex of the heart are the opposite of the lungs, okay? So the apex of the heart is towards the bottom of the heart, and the base of the heart is at the top of the heart, okay? So it is marked here on this picture as well. Oops, sorry about that. It has two pump systems that we'll get into, and each side of the heart has an atrium and a ventricle. Notice two atrium on top, two ventricle on the bottom, okay? So the atrium is a thin-walled reservoir for holding blood. Ventricle is a thick-walled muscular pumping chamber, okay? So the atrium fill up and then we'll release the blood into the heart, the ventricle. The ventricle pumps into the blood towards the lungs, okay? And then it also pumps it towards the body. And we'll get into more detail as we go through the slides. So here is, the picture of the heart. As you see, it has two atrium, okay, two ventricle, which are the bottom chambers of the heart. There are two AV valves or atrial ventricle valves on the left side of the heart. Now remember, it's the heart's left side, not our left side. So on the heart's left side is the left AV valve, which is the mitral valve. And on the right side of the heart is the tricuspid valve. Okay, so two AV valves, the tricuspid and the mitral valve. Then there's also two semilunar or SL valves. Okay, so the semilunar valves is the pulmonic valve, okay, and the aortic valve. So the pulmonic valve is on the right side of the heart. That's where the ventricle is pumping the blood, the oxygenated blood, into the pulmonary artery through the pulmonic valve, and that's how it gets to the lungs, okay? And then the oxygenated blood then will come back into the pulmonary veins, go into the atrium, and then go into the ventricle, and then the ventricle pumps it or contracts and squeezes it through the aortic valve, okay? So the semilunar valves, they have three cusps that look like half moons, okay? So you've got the AV valves and semilunar valves. Okay, so 4 total in the heart. So, I went through all of this. Let's see. All right, well, I'm going to move on to the next slide. So now we're going to talk about the route of blood flow. I kind of started that up in the last slide, but the valves like your AB valves, they only open in one direction, so they're unidirectional, okay? And the valves open and close passively in response to pressure gradients in moving blood, like I explained. So the deoxygenated blood goes into the right aorta, goes through the tricuspid valve or the right AV valve, then the right ventricle will contract and push it into the pulmonic valve. It goes through the pulmonic vein, goes into the lungs. The lung does its thing in there. It shakes it around, gets some oxygen and nutrients in there. Then it will come back through the pulmonary vein into the left atrium, go through the mitral valve into the left ventricle, and then the ventricle will contract and push it through the aortic through the I'm losing it, aortic valve, and then it will go through the body. And it's an ongoing cycle, okay? Deoxygenated comes in, oxygenated blood goes out, okay? Just to review, the AV valves open during heart's filling phase or during diastole to allow ventricles to fill with blood. During the pumping phase or systole, AV valves close to prevent regurgitation of blood back up into atria. So remember, the AV valves are unidirectional, only goes one way. If there is an issue with the valves, that means there's regurgitation of blood happening, and that's not what we want, okay? So just remember systole and diastole. So with the cardiac cycle, as I just mentioned, just understand systole and diastole. And on here, I said it backwards, but that's okay. Diastole is the ventricles relax and fill with blood. Systole is the heart's contraction. Blood pumped from ventricles, filled pulmonary and systemic arteries. Okay? Same events occur on both sides of the heart. So as we have discussed, the heart sounds are lub-dub. Okay? So the first heart sound is S1. This occurs with the closure of the AV valves. Okay? So this is the signal of the beginning of systole. Okay? So that's lub. And the second heart sound, S2, dub. This occurs with the closure of the semilunar valves. That signals the end of systole. Okay? So, lub-dub, S1, S2. S1, closure of AV valves. S2, closure of semilunar valves. Now, I've kind of mentioned in class about murmurs, okay? Murmur is a extra heart sound. It is not the norm, but it does happen with patients a lot of times. I heard a murmur for the first time during my clinical time when I was in my nursing program, and it sounds like a swoosh, like a swoosh sound, swoosh with the lub-dub. You hear it in there. So I just want to let you know it's an extra heart sound, and murmurs sound like a swooshing sound, a gentle blowing swooshing sound that can be heard on chest wall when you're listening to heart sounds. Okay? So with conduction, we as human beings do not control our heart beating. The brain controls the heart. So the heart beats automatically or elasticity. It can contract by itself, independent of any signals or stimulation from the body. Okay, so we have nothing to do with the heart beating. So it contracts in response to an electrical current conveyed by a conduction system. So the SA node, or the sinoatrial node, initiates an electric impulse. And because the SA node has an intrinsic rhythm, it is called the pacemaker. Okay, so it helps to keep the heart beating in a regular rhythm. The SA node, or the sinoatrial node. You hear sinus rhythm, sinoatrial. Okay, so when we look at an ECG, EKG, we want to see a regular rhythm or sinus rhythm. And that's because the SA node is the pacemaker of the heart. So as I was just discussing, the electrocardiograph, ECG, I have a couple pictures that I'm going to attach, which is after this slide. That kind of shows you that the ECG waves are arbitrarily labeled PQRST. Okay, so the P wave, and you don't need to know this. So, you know, when you see an EKG, you can kind of have a general idea. You've got the P wave, the PR interval, okay, the QRS complex, the T wave. So what can be seen through an ECG, EKG is if the heart is beating a normal rhythm, which is sinus, is it tachycardic? You'd have to take an EKG class. You can see if someone is having an MI or a heart attack. That's when you hear, if you're in the hospital, the ER may put over the intercom that there is a STEMI. So a STEMI is an ST elevated myocardial infarction. So with this picture here, you can see the P wave, then the QRS. So if the patient was having an MI, that S and the T wave would be 1. So you see that ST segment. So I don't expect you to know that, but I wanted to share so that you can see what an ECG is. Usually those individuals who work in ICU, ED, within the OR, surgery, learn how to read EKG, ECGs, but not everyone has to learn how to read them, but they're very cool. So let's talk about the neck vessels. Okay, so we've got the carotid artery and jugular venous pulse. Now notice carotid artery, jugular venous. Okay, so we know that arteries pulsate. Arteries you have to press in, and usually veins are very superficial, close to the skin, so you can see them. Okay, so the carotid artery we have discussed during lab. That is the pulse that we use when we are doing CPR. Okay, so you know how you have to use your 2 fingers when you're checking another person, and it's to the right or to the left of the throat, or left or right side of the neck. Okay, your jugular venous or your jugular veins, you don't see them, and they're towards, and there's a picture coming up. The jugular veins are behind, in a sense, the carotid artery, and you're not supposed to be able to see those unless there is some type of disease process going on, like congestive heart failure. Oh, so down here with developmental competence, you see I bolded aging adult, okay? So closely correlated with lifestyle, habit, and diseases. So we have to discuss with our elderly about heart health, discuss lifestyle, diet, alcohol use, smoking, stress, okay? This can very much so have an influence on CAD, which is coronary artery disease, okay? Hemodynamic changes with the aging. So, I'm totally ahead of myself. So, pressure pulse changes, okay? Isolated systolic hypertension, oh my God, my puppy. Increase in systolic blood pressure due to thickening and stiffening of the arteries. This happens a lot as individuals age. The left ventricular wall, so the left ventricle wall can become thicker, but the overall size of the heart does not change. These are pretty normal changes with age. The pulse pressure increases. So let me tell you what a pulse pressure is. This is the patient's systolic number minus the diastolic number. Okay, so it's the top number minus the bottom number. So for example, if the patient's resting blood pressure is 120/80, we would do 120 minus 80. The pulse pressure is 40, okay? That is a healthy pulse pressure. But usually pulse pressures greater than 40 is usually unhealthy. There's something going on in there, okay, with the heart. So there should be no change in resting heart rate or cardiac output at rest. And the ability of the heart to augment or become enlarged, cardiac output with exercise is decreased. So the patient doesn't have, the aging adult doesn't have as much heart energy as they did when their heart was younger, okay? So dysrhythmia. So a dysrhythmia is an abnormal rhythm, okay? And the abnormal rhythm can be seen in an ECG or EKG. The picture that I showed you of the PQRST, any abnormal heartbeats would be shown there, okay? So a dysrhythmia, once again, is irregular, but the heart rate is still within normal range. And then an arrhythmia, ARRHYTHMIA, is where the rhythm of the heart is either too fast or too slow. And as you see here, tachyarrhythmias may not be well tolerated in older people. So a lot of times, if the patient has an arrhythmia, a pacemaker would be inserted, which is a surgical procedure to help to regulate the too fast or too slow rhythm, okay? Cardiac disease in the aging adult. So the incidence of CAD increases sharply with aging and accounts for about half of the deaths in older people. So, some of the vessels will become a little stiffer. And CAD, we've got all kinds of a lifetime of plaque and stuff They may be sticking to the walls of the vessels. So hypertension and heart failure also increase with age, as well as lifestyle habits play a significant role in the acquisition of heart disease. So if our aging adult is active, eats healthy, has been doing so for a while, their chances decrease of being terribly sickly as they get older. And of course, if they are sedentary, unhealthy, doing all kinds of crazy stuff, it won't be such a healthy aging time, okay? So increasing the physical activity of older adults associated with the reduced risk for death from cardiovascular disease, CVD, and respiratory illnesses. So both points underscore need for health teaching as an important treatment parameter. So when we are assessing our elderly patient, really any patient, we want to make sure we do a lot of health promotion teaching, and we'll go over this again towards the end of this recording. So it is about lifestyle, about nutrition and eating and activity, things along those lines. We should do a lot of health promotion teaching. Oh dear, I don't know what happened to this, but so CVD is the most common underlying cause of death globally. As a whole, cerebrovascular disease is just horrible. Cerebral. Cardiovascular. I just went right into the brain. Sorry, cardiovascular disease. Okay, so although all adults have some potential CVD risk, we have to be competent in regards to culture and genetics. So some groups defined by race, ethnicity, gender, socioeconomic status, that is huge, because we don't know all the variables that are occurring in our patients who come in for why they eat the way they do, why they're not active. We don't know all of it. So socioeconomic status can very much play a huge part in the health of our patients, and educational level, okay, carry an excess burden of cardiovascular disease. So we recommend favorable lifestyle. We consider access to care because there are some communities that do not have easy access to care. There are a lot of individuals who will not see a primary care physician but will use the ED as a primary care destination, for lack of better words, because access to care isn't so easy, and payment for care isn't so easy, and the ED cannot turn you away as primary care physicians can turn you away, or practitioners, I should say, can turn you away. So we have to look at the entire picture of our patient. There are risk factors. So as we're assessing our patients and collecting their health history, identification, early treatment, and health promotion, all of that education can assist with so many risk factors. We just have to pay attention to the information we receive from our patient. So risk factors are hypertension, cholesterol level, smoking, physical activity, sex and gender differences. Can also be a risk factor for different issues. So let's talk about subjective data that the patient can share with us, okay? So here are some examples of subjective data that the patient could discuss with us. It could be based on their chief complaint of why they've come in to see the doctor, or just it could be something that they want to discuss, okay? So the questions down here at the bottom: past cardiac history, family cardiac history, any cardiac risk factors. These are all very important, and all this information is very important to collect. So I will leave that for you to take a look at. And as we've discussed in lab, as we do our physical assessment, our head-to-toe assessment, for each system, 3 pertinent questions or 3 important questions for that system needs to be asked by the nurse to the patient. That will be a part of competency. So here's an example of chest pain questions. Okay, we ask the patient, have you experienced any chest pain or any tightness? If so, then we ask about onset and location, characteristics. What was going on before we had the chest pain or tightness? What other symptoms did you have with that? What was it relieved by or made worse by? Were you active when the chest pain or tightness happened, and when you stopped exercising, it went away? Or did it make it worse? So are you on medication or any treatments? Did you take any medication or any treatments during the chest pain or tightness? So we need to make sure we ask relevant questions during our assessment. Okay? Dyspnea questions. As we know, dyspnea is difficulty breathing or shortness of breath. Okay? So we ask the patient, have you experienced any shortness of breath? And then if they say yes, you ask about the type of activity, when it occurred, when the onset, when did it start, how long did you feel short of breath, effect of positional changes and interruption of sleep, okay, the presence of orthopnea, and did the shortness of breath affect your ADLs, your activities of daily living? Did you have to take breaks while you were brushing your teeth, while you were getting dressed, your ADLs? So, do you have a cough? If they say yes, we ask these questions, okay? I've kind of gone through the previous questions, so you can read through this. And, okay, so do you seem to tire easily? Okay, and what part of the day is this happening? Do you have more issues during the day or when you're laying down to go to sleep? So this is some additional subjective history questions. You can ask about any occurrence of these things: nocturia, which is having to pee a lot at night; cyanosis or pallor. Do you have any blueness? Do your fingertips turn blue? Do your lips turn blue? Do you have orthopnea? Do you have any issues with edema, swelling? Okay, when and how long? Okay, how much edema? A lot of edema, and where are you feeling that edema or experiencing that edema? We ask cardiac history questions. We ask about, once again, past cardiac history, any medical history or surgical history. Oh my gosh. Any diagnostic testing and imaging studies. Have we had to do any EKGs recently? Have we had to do any echocardiograms? Have we had to do anything as such? Do you have family history of cardiac issues? If so, which side of your family, maternal or paternal side? Then patient-centered care. Determine information relative to patient history. Okay? Nutrition, alcohol, all of those things. All right? So we talk about functional assessment. We ask all of this. What are you doing? Yeah. So additional history for our aging adult. We may have to ask some additional questions. Their medical history. Review presence of comorbidities. Do they have high cholesterol? Are they diabetic? We want to make sure we collect any comorbidities. Medication profile history. What medications are you taking? What are they for? When do you take them? What's the dose? Do you know what the side effect of medication 1, medication 2, medication 3? Most patients have no clue about side effects. And that's part of our responsibility with our patients, is to teach them about side effects and adverse effects. We ask the patient, are you compliant with the therapy? Meaning, are you taking it as you're supposed to every day, the correct dose, okay? And the correct time. And their environment and the impact on their ADLs. So when we're going to do our assessment, we need to make sure we prepare what we need prior to the patient, prior to us going into the patient's room or the patient going into the examination room. Because I don't want to base everything around working in the hospital, because there are many different environments that nurses work in. So, to evaluate the carotid arteries, the patient can be sitting. To assess jugular vein and precordium, the person should be supine with head and chest slightly elevated, okay? So the patient should, when we're checking the heart and the cardiac system as we are being taught during this course, the patient should be maybe at a 45-degree angle, okay? Because you are going to be palpating and auscultating the carotid artery. The patient is going to have to turn their head to the right for you to assess one side, and to the left to assess the other side. And when the head is turned to the left or right, you are also going to be looking to see if there is any jugular vein distension. Okay? Want to make sure we ensure any privacy needed. We're not going to be undressing our classmates, but if it is a requirement that our patients, whatever environment we work in, have to take their top off, or they're wearing a gown and we have to bring the gown down to take a look at the precordium and anything on the chest, we should keep their privacy. So what we need is a marking pen, just in case there's any abnormalities that you want to mark on the patient's body. A ruler if necessary, if you need to measure, a stethoscope or diaphragm, and bell end pieces. So when assessing, or I should actually say when auscultating the carotid arteries, you're going to need to use the bell of a stethoscope. Okay? And then we'll need alcohol wipes to clean the end piece. But also during preparation and equipment, when we enter the room, we are to do hand hygiene. You gel in, you introduce yourself, you ask the patient their name, their identifiers. Then you also want to make sure you check the patient's level of consciousness. Okay, so along with their name and their identifier, do they know where they are? Do they know why they're there? But make sure you provide privacy via a door or curtain. Okay, this is absolutely important, and it should be done whenever you are with a patient during any kind of assessment. Okay, and for any competencies. Let's move on to palpation and auscultation. As I stated, we're going to palpate the carotid artery. Okay, you only palpate one at a time. We're not trying to compromise arterial blood to the vein, the brain. So we're not going to try and palpate both at the same time. So one carotid artery should be palpated at a time. Okay. You want to feel the contour and amplitude of the pulse, right? The normal strength is 2+. Okay. And when you assess both, the assessment should be the same bilaterally when you palpate. Then you're going to auscultate the carotid artery. Okay, so the patient, like I said, should be about a 45-degree angle, the highest. You're going to have them turn their head either to the left or the right. You will place the bell of the stethoscope, okay? Lightly going to apply it at the angle of the jaw, okay? Where you would feel the carotid artery. You would come down towards your clavicle, but on the neck there. You're going to listen mid-cervical area, and then listen at the base of the neck right there by the clavicle, okay? When we're inspecting, okay, you want to inspect the jugular venous pulse. So, do I have a picture here? Yes. So, from the jugular veins, you can assess central venous pressure and judge the heart's efficiency as a pump. So, as I stated earlier, you should not be able to see the jugular venous pulse. You shouldn't be able to see the jugular vein unless the patient is having issues, okay? So you want to make sure you observe for possible distension of the jugular vein. So if you see the jugular vein, that means it's distended, and that's an abnormal finding. So characteristics of jugular vein carotid pulsations versus, you want the location, quality, respiration. Oh, you want to differentiate, between the location, the quality, the respiration, palpable pressure, and position of patient. We'll discuss it a little further, okay? So here is the picture. As you see here, red in the, okay, so the middle of the neck here, that is your esophagus, your throat, that is your thyroid, the larynx, all that good stuff. To the right and the left, you see the carotid artery, okay? The carotid artery. And further back on the neck, you see the right jugular vein and the left jugular vein. So they're in two distinct, different areas of the neck, okay? So let's talk about the precordium auscultation. So you're going to have to understand where the 5 heart sounds are that you are going to be responsible for, okay? So you're going now, the valves and the locations that we are discussing are the best spots to hear the valve, okay? But it is not the exact spot where the valve is located. It's just the best spot to hear those sounds, okay? So, if you're looking at the patient, if you see yourself as a patient, okay, you have your sternum, then you have the right side of your chest and the left side of your chest. So, the second intercostal space to the right side of the sternum is where you would hear the aortic valve, okay? The second, okay, let me start over. You have your sternum. The second intercostal space to the right side of the sternum is where you can hear the aortic valve. So the second intercostal space to the left side of the sternum is where you hear the pulmonic valve. Then in the third intercostal space to the left side of the sternum, you will hear Erb's point. Okay? The fourth intercostal space to the left side of the sternum, you will hear the tricuspid valve. And then the fifth intercostal space, mid-clavicular line to the left of the sternum, you will hear the mitral valve. It is in the same area as the apical pulse. Okay? So, the only valve you'll hear on the right side of the sternum is the aortic valve. Then on the left side, second intercostal space, pulmonic valve. Third left intercostal space is Erb's point. Fourth left intercostal space is tricuspid valve. And the fifth left mid-clavicular line, you'll hear the mitral valve. Okay? So you should be able to identify S1 and S2. Where would you hear that? If you hear any extra heart sounds like a murmur, you should be able to describe the characteristics. So with the murmurs, you should, the timing, the loudness, the pitch, so on and so forth. But it's very, you probably won't hear it, but you may hear it. You just might. So here are a couple of pictures. I don't particularly like these pictures of where you would hear the aortic valve, where you would hear the pulmonic valve, Erb's point, the tricuspid valve, and then the mitral valve, okay? So A, P, E, T, M. That's how I remember it. This I uploaded. I prefer this picture. It's a little bit clearer as to where you should be hearing all of these heart sounds, okay? A, aortic, P, E, T, M. So, second intercostal space, right side, aortic. Second intercostal space, left pulmonic. Third intercostal space, Erb's. Fourth intercostal space, tricuspid. And then fifth intercostal space, mid-clavicular line is mitral valve. Down here, aging adult. I'll have you take a look at these. We've kind of discussed it already. You can just read it as a review. So as nurses, once again, we do a lot of education with health promotion and patient teaching, okay? If the patient is on aspirin therapy, we make sure we take a look at that. And if they are, we make sure we discuss appropriate aspirin therapy. We want to talk about and teach about blood pressure control, cholesterol, their diet, cessation, lifestyle changes, diet, physical activity, weight control, give suggestions, give some education of why they should and shouldn't do these particular activities, okay? This is just a picture, okay, that I thought would be helpful. Like I said, to be able to see the jugular vein or jugular vein distension, that means that there is something, a disease process going on, because it's not normal to see the jugular vein. And as you see here, it is distended, and that is what it looks like, okay? So I just wanted you to see a clinical portrait of heart failure, okay? We talk about edema. We talk, because ascites is kind of a form of edema, but it's fluid buildup in the abdomen or the peritoneal cavity, okay? This is just, I like this picture. I thought I would share it. Okay. I believe this is our last slide. So, summary checklist, heart and neck vessel examination, okay? So, when we're assessing the neck, we're observing and palpating the carotid pulse, and we're auscultating the carotid pulse in 3 areas. So we observe, palpate, auscultate. We are observing for jugular venous pulse. Okay, we're estimating jugular venous pressure. The precordium, we would usually inspect it and palpate the apical pulse, describing the location of the apical pulse, and if you feel any lift or thrill. Okay, we talked about auscultation. So we want to listen at the apex and the base. Make sure you understand that. We use the bell along with using the diaphragm of the stethoscope. Okay. Make sure you identify the anatomic areas, noting the rate and rhythm when you are listening for those heart sounds. So I am, of course, going to say practice, practice, practice on anyone who will let you listen to their heart, their lungs, any of the assessment.